Well, we are at 4 o'clock, so we will go ahead and get started. Thank you all for joining us for our first ever virtual alumni event here at SUU. For those that don't know me, my name is Ron Carden. I'm part of the alumni relations team here at SUU. And like all of you, we're disappointed that we're not able to do all of the regular events and things that we are normally able to do, but we're so excited to also launch a few virtual type things that we think obviously will extend through the summer and also into the fall and winter months, most likely. We are billing this as a Learning Lives Forever, virtual events and learning opportunities for alumni. And we're doing a bit of a soft launch this month. And next month, there will be a little bit more going on. And so we invite you to watch your monthly e-news for that listing. Some of them will be Zoom calls like this. Some will be done via social media. And be sure and follow us on Facebook and Instagram. Just a couple of housekeeping items. I think everyone knows if you'll keep your microphones muted, that will help with the feedback. If you have questions, there's the chat feature, there's the raise your hand feature, and Cole Gibson from our office is in there with Jarid Gray to help with those questions so that Jarid can focus on talking and not having to read comments and questions. And Cole will also be, we don't anticipate any problems, but there was an office on campus who had a Zoom class last week that had a hacker that caused a little bit of grief. So Cole is also monitoring so that we can act quickly on something like that should it happen. So with that said, we are thrilled to have Dr. Jarid Gray with us. So appreciative of him taking time out of his busy schedule. He's a graduate of SU, of course, and a Sigma Chi brother, and I see Sigma Chi and Alpha Phi, and it's wonderful to have you joining us. And as was billed, he spent some time back in New York as part of a Intermountain Healthcare contingency to go and work in those hospitals. And so, Jarid, we'll turn the time over to you to talk about your SU experience, a little bit about your career, and then New York.
Thanks. So despite there being at least 900 Zoom meetings in my house with my kids, this is actually the first time I've ever participated in Zoom. So hopefully bear with me. As I mentioned, I'm Jarid Gray. I'm a graduate of SUU from 1995. I entered SUU as a junior college transfer. I spent 2 years at CEU in Price and came to SUU in the fall of 1993. When I came to college, I was a painful introvert. I was, a smart guy who did not know how to negotiate my way around crowds. And so I looked at coming to SUU as a chance to kind of reinvent myself. I started to try to become involved in clubs and get to meet more people. I joined the AED, which was the pre-professional club when I first got to campus, and made one of the more meaningful contacts in my life at that time. Tony Cirillo was the president of AED at the time, and I got involved with that. And he ultimately pulled me in a lot of directions that I would generally wouldn't have done myself. He asked me to join his party for an attempt to run for SUU Senate, which I did. He also encouraged me to join Sigma Chi, and I did both of those two things the spring of '94. And those two activities probably were seminal moments in my life. And I can't see me now. How do I get back into this? Can you see it? There we go.
There you go.
And sometimes you have something happen to you at the right time with the right group of people that make a meaningful impact in your life. And I can say with no hesitancy that if I had not become involved with student government and Sigma Chi, the likelihood of me getting into medical school would go down, and I certainly would not be as good of a doctor as I was because of those interactions. I graduated in the spring of 1995 and entered the University of Utah in the fall. I spent my 4 years there. I then did my postgraduate training in family medicine, and spent my time in Pocatello, Idaho, working between Bannock Medical Center and Pocatello Medical Center for 3 years. And then I returned back to SUU, or not to SUU, back to Cedar City in the summer of 2002 and opened private practice. I spent 4 years as a solo provider, and then had my first partners join me in 2006. The time I spent in private practice, I did a full spectrum practice. I did obstetrics, I did inpatient medicine, outpatient medicine, pediatrics. And then about 2012, 2013, I started realizing how much my practice was interfering with my personal life. I was missing a lot of my kids' stuff and becoming frustrated. So I started paring back and looking for something that would be a little more regimented and scheduled. And with that, I discovered a subspecialty of our profession called a hospitalist, which is basically inpatient adult medicine. And I started doing that part-time in 2011, and in 2014, I divested myself from my clinic and became a full-time hospitalist, working across a couple of Intermountain facilities. I also did some time working out on the Navajo Nation at Tuba City and Kayena hospitals. And so that's what brought me up to this point in my life. And the first week of April, we received an email through the hospice group about Intermountain was going to put together a couple of teams to go out and assist in New York. I had to reply and answer within 3 days. I sent my reply off the next day, saying that I would like to be involved. There were over 800 people who volunteered for 100 spots. I was thankfully chosen, and had 3 days to prepare, rearranging my home schedule, rearranging my work schedule, and getting everything else ready to go. People ask me a lot of times, why did I volunteer to do this? And frankly, it's just what you do. This profession, you take, excuse me, you take all this knowledge that you gain and you hope that it becomes meaningful for somebody else. And I was looking at the suffering that the people were experiencing out there, and I was looking at the overwhelm that our professional colleagues were having, and you run to that to assist them because you know what that's like, either in watching patients in other places, watching them suffer, and then also you understand what it's like to be professionally overrun by your work. And so that was kind of the main reason. The secondary reason is we wanted to bring knowledge about how to treat this disease, how the things that they had done well, the things that they wish they had done better, and try to bring that knowledge back to our system in Utah to be able to help us if we were to ever have a massive outbreak or something similar to what they experienced in New York. So with that, we flew off from Salt Lake to New York, and we landed in JFK, and it was a ghost town. If you subtracted the 50 people in our group, there were I saw probably a net of maybe 70 or 80 other people in the entire airport. We then went to our hotel. They fitted us with our N95s, kind of did an orientation about their safety processes. And then the next day we started orientation. And I can honestly say, despite having a sense of what I thought I was going to see, there was nothing that could prepare you for seeing the magnitude of what this outbreak was in New York. And that's in the quantity of patients and then the severity of their illness. The hospital I worked at was Long Island Jewish Medical Center, part of the Northwell Group. They are a 580-bed hospital on a regular basis. They have a 35-bed ICU. In the weeks leading up to us coming, they had a massive surge of patients. They rapidly expanded their hospital capacity out to about 800 beds, and expanded their ICU capacity to nearly 200, and filled those beds to the gills. 90 to 95% of the patients were COVID positive. They did have a small population of people who were not. By the time we got there, so they capped out at nearly 800 patients. By the time we got there, they were down closer to about 720, 730. The majority of them were, again, still COVID positive. And they still had an ICU census of 170 patients that were on ventilators. On the medical floors, which is where I started, at least half of the patients that I was taking care of on a regular medical floor would be likely patients I would take care of in an ICU in our facilities here. So that kind of points to the severity of the illness. And these people were, most people had this perception, and I did certainly before I got out there, that this was primary respiratory illness, that it causes pneumonia, it causes infection in the lungs. As we learned, and I learned quickly, is this disease impacts multiple organ systems. Particularly, it causes a lot of vascular complications with clots, which then in turn lead to strokes, kidney injury, pulmonary embolism, which are clots in the lung. It can also cause heart attacks. It also causes a condition called myocarditis, which is a viral infection of the heart muscle itself, which causes heart failure. During my time there as a hospitalist, during the first 8 shifts I did, I discharged only 2 patients from the hospital. Many of these patients were coming to the hospital and staying 10, 15, some as many as 30 days in the hospital. And some of them weren't even close to being discharged. The other thing that was so intrusive that it's hard to describe is the overhead calls for rapid response, which means a patient at risk of decompensation, code blue, which is a patient who is in the process of dying, or a call for intubation to place a patient on a ventilator. It was so many the first day. I started counting them, and on the first day we had 28 overhead calls in between 8 a.m. and 6 p.m. The lightest day while I was there was 12 calls overhead, and the average was about 20. By comparison, in the hospitals I worked at, and I've worked at Dixie Regional Medical Center, McKay in Ogden, I've worked at Riverton as a hospitalist, and then Cedar City. I probably have responded to 50 overhead calls in the last 6 or 7 years. Just this ever-present oppressive sound coming from above, and it interrupts what you're doing. Okay, is that my patient? Okay, no, that's not a patient that I'm responsible for. Am I on that unit? Okay, I am, so I need to go respond to that. It's just unheard of to see that much need for rapid or emergency services. The second part of my stay, I spent 3 days in the ICU towards the end of my stay, and on that stay, we responded to the calls for intubation, because if they were intubated, then they would become ICU patients. And on those 3 days, we responded to about 15 calls. On those calls, excuse me, my allergies are killing me. On those calls, we talked to the family directly on each one of those calls to see, this is the prognosis of your loved one, that if we place them on a ventilator, this is the probability they'll recover. Do you want us to proceed? And about half the people, after we talked to them, decided not to, and we placed their family on comfort measures. The other thing that was striking and really kind of a tragedy to me was these patients are all alone because of the fear that they can spread it to other people and those people can spread it to other members of their family. These patients were not allowed any visitors. The medical staff were the only people that would attend to them. Some of them were able to talk to their family by Skype or by FaceTime, but many of them were not or did not. And many of these patients we took care of that died, they died alone. They died with a nurse at their bedside or a medical provider, but they did not have their family present. And that is such a disconnect for what normal medical practice is. We strive to be present to help families through this process, to help them grieve, and ultimately it allows us to grieve as well, and helps us to kind of move on to the situation professionally. As doctors and nurses, you get used to death. Death is part of the equation when you sign up for this job, but the magnitude of the number of people that were passing was just unprecedented in anything I've ever seen. And I do think that there's going to be a lot of concern in my mind for medical providers who take care of these patients for mental health issues, depression, anxiety, PTSD even. And so I think that's going to be something as we see the surge kind of die off there, that then these mental health issues are going to come about. There are a lot of people ask me why has this not impacted all parts of the country equally, and that's kind of a good question. And I'm not an epidemiologist. I don't try to pretend to be one on my side job either. But when you look at infectious disease, it requires to get a major outbreak, you have to have a certain number of patients who get sick in the same area to allow the disease to spread rapidly. And the best analogy I can think of is if you take a large field of dry grass and you want to burn the whole field down, you're far more successful if you start 15 or 20 small fires through the field than one big fire in a corner, because there are factors that can make that one fire go out or not spread as much. But if you start the fire in multiple places, and so compared to other places in the country, there must have been a lot of seeding of infected people throughout a fairly diverse population on the East Coast. And if you look at the genetic fingerprint of the virus that's infecting New York and New Jersey, they can tell that outbreak was transplanted from Europe. It came from Italy and from Spain and possibly Germany as well. That seems to be the sources of the infections that hit the East Coast. Excuse me. Comparing to the West Coast, where the majority of the cases came from China. So if you compare our national responses to those two places, we did not shut down travel. It wasn't announced that we were going to shut down travel from Europe until March 14th. I don't think it was actually shut down for a couple of days. I read something in one of the local papers in New York while I was there that about 140,000 people flew into JFK and LaGuardia from Italy alone in the month of February, and that number continued through the middle of that month before air travel stopped. And so when Europe was experiencing their major outbreak, there were still lots of travel and lots of interaction with people from those areas, and I think that's where they seeded from. These people were coming to visit family, they were coming to sightsee, they may be coming for business. Compared to the outbreak that came from China, flights from China to the United States stopped in January 30th. The Chinese put Wuhan and the Hubei province under martial law and basically no one could come or go from that area starting about January 14th. So there wasn't as much time for that virus to spread through multiple people to the West Coast. The majority of the outbreaks in the United States that came from China were U.S. citizens coming back from those areas. The outbreak in Washington State specifically came from a student who had been studying in Wuhan and went back home. The next thing that happened is domestic travel. Starting sometime about mid-March, domestic travel in the United States nearly completely stopped. People stopped traveling to and from their home to New York specifically. And so that's blunted the spread of the disease through other parts of the country. If you get 1 or 2 cases in a town of 40,000, and you can isolate those cases, you actually will avoid a lot of spread. But if you end up with 30 or 40 cases in that same town, it's much more hard to isolate, and you're going to get more of an outbreak. And so I think simply, more than anything, other areas became geographically isolated from the East Coast. There was less travel into the Midwest, in their Mountain West. And the outbreaks on the West Coast, because it was fewer, there was not as much seeding from those areas. They stayed a little more contained. And so I think that's one question people ask. The last thing I want to talk about, and then we'll take questions, is people focus a lot on deaths, and rightfully so. There's a lot of suffering along with this, but I want to talk a little bit about patients who survive this condition. When we were leaving New York, the CEO and vice president of Northwell came and gave us a farewell. And I was asking questions about kind of what their next steps were. They're a 13 hospital system in the New York area. They figured over their 13 hospitals, they had about 300 to 350 patients at that time that they felt were never going to be able to get off a ventilator. Their lungs had been scarred and injured so bad that they would not be able to breathe without the assistance of a machine the rest of their life. And these were people who were recovering from the illness and were clearly getting better, and we're not going to die. And so the impact that those patients are going to have, both from an individual and a family standpoint, financially and society-wise, the majority of these patients will end up on Medicare and Medicaid because they are not going to be able to work. They will be on disability. Most of them will live in nursing homes and be on ventilators. And that's as a physician, I would say there are certain things that are worse than death. That's kind of in the ballpark. The second thing is a condition that occurs when people are either on a ventilator prolonged or an ICU prolonged and recover. And most of the data on this is based on a condition called ARDS. And some of the research has been in Salt Lake. But they followed these patients after discharge who had successfully survived this disease, and the median time on the ventilator for them was about 13 days. And then they followed these patients for 3 years, and they tracked their physical health, their psychological health, their social health. And they found that the impact of that hospitalization for those patients many times extended even as far into their life as 3 more years. They were physically weak because of laying in bed, so they weren't able to physically do the things they needed to do. Many of them described nightmares and PTSD. Some of them described, even though they were completely sedated, they described watching nurses come in and cut them open and do surgery on them. And these are the effects of the medicines that people receive to keep them sedated so you can treat them. And ultimately, what the research on this recommended was kind of a modality approach to these patients, that they needed to be followed by physical therapists and their physicians and psychologists and even psychiatrists as soon as they leave the hospital. And so there's going to be a lot of people who survive this that are not going to go back to work. Within 2 weeks of leaving the hospital, they're going to have significant disabilities over time. And I don't think we'll get a good sense of what this outbreak looks like in that regard for a year. And but I think people lose sight of that sometimes. We focus on the dead. I focus on the survivors, because there's going to be a major impact for a lot of people to survive the major hospitalizations. So, all right, I think I've covered about what I want to. If you want to take questions, we'll go from there.
Hey, Dr. Gray, what was like the average age of those that you treated?
When I was on the medical floor, the average age was about 61. Most of them had one or two comorbid conditions, with the most common being hypertension. The second most common was diabetes. The perception I had is I expected to see patients who had a higher burden of medical illness than what I saw. The patients fit in with conditions that I kind of joked that they seemed even a little healthier than the average patient I take care of on the hospital. But they were kind of average medical patients, average Americans as far as their health problems at that age.
The question that's been chatted is, how prepared is Utah for potential surge?
So the question was, how prepared is Utah for a potential surge? I think we've prepared about as much as we can. I know the University of Utah and their health system have undergone many of the things we have at Intermountain. We have a long-term and short-term plans on changing some of our medical units into ICU care, which seems to be the big thing that New York wasn't prepared for. They thought that they'd be able to manage the patients in their standard volumes, and that they clearly became not the case. But we have a program set up to mobilize basically every medical physician we have to help in the hospital if able. And I think we're about as prepared as we can be. I think Mike Tyson, one that said, is everyone has a plan until they get punched in the mouth. And we won't know how well our preparations, we won't know how well we've prepared till we would actually encounter it. And I hope we don't see what I saw in New York here.
Another question from Kim Bateman is, what are the pros and cons of opening up public education in the fall? Some states are returning as early as August.
I think this is the $5 trillion question for everybody. Ultimately, I think we're going to have to learn as a society how to live with this disease. A vaccine is not anywhere in our imminent future, and I have some personal concerns that to get a vaccine that will be a once and done is going to be a pretty much a long shot. So what I think that if you're in an area where there's not a significant amount of outbreak, and you have the ability to test and isolate those who are infected, that we should work forward to trying to open up schools in the fall. Maybe it won't look the way that we're used to. I know that in high schools they do an A-B system. Maybe half the students come to school on A, the other half on B, and then they're doing Zoom on the other times. We have to figure out how to run our society with this disease in mind. And so I think it's, if you're in the middle of a crisis outbreak, schools need to be closed. You need to keep people home. But if you're in an area where there's low outbreak or very minimal cases, we need to allow society to function. But you need to be willing to rein it in if you start seeing a significant spike in cases in your area.
Someone asked that you repeat the question just because they
Okay, sorry.
But another, Charlotte asks, do you think that wearing masks is necessary while being out in public? She's seeing conflicting information and what can you say to help about this topic?
All right, so the question is about wearing masks in public and how, what, with all the conflicting information, what you would recommend. So let's talk some basics about masks first. The real gain to a mask is to keep me from transmitting illness to you, not to protect me from getting sick from somebody else. If you look in an OR situation, the surgeons and the assistants all wear masks to prevent them from spreading an infection to the patient on the table, not to protect them from getting an infection from the patient. So the second thing I would say is that in regards to public, I think there's little utility to wearing masks out in the outdoors, in open air places, unless you're in very crowded quarters. As far as wearing masks in inside places, to me, and maybe the best way to describe this, I'm going to tell you what I do. I do not wear my mask in my car unless I have other people who are not my immediate family with me. I do not wear my mask when I'm outside walking. I do not wear my mask when I'm doing other things. But when I walk into any store, I put my mask on. And that is so that it's not to protect me. It's to reduce the risk that my cough, and this applies to any infectious disease, it really does. It keeps me from coughing on things and then the next person coming in and touching it. And so I think the recommendations to wear them inside is actually pretty sound. It's based in some decent science, but it requires everyone else agreeing, and that seems to be some of the trouble with it. But I would say that, if 20% of people are wearing masks, that's better than none. If 50% were wearing masks, that's better than 20. And I think as we just continue to say this is kind of the norm that we're gonna have to deal with, you're gonna see more people help out with it. But I like I said, I don't wear them outside. I don't wear them in my car. I do wear them in any inside places I go where there are other people.
And that partially answered a question from Jeremy Jenkins, but he also asked what other personal precautions are you taking to avoid getting sick?
So the main thing is, especially when you've come from an area where you don't know what's going on, it's not touching your face. I don't think I realized how much I like touching my face until I was told I couldn't. But what I do is when I'm going to Walmart, I sanitize my hands before I go in. That's again to protect other people. I put on my mask and then I do my thing. And then when I get back out to my car, I sanitize my hands again. So that's to protect me, so that anything I may have touched in the stores I'm not going to take home with me. And I think that's kind of the sound advice. Always wash your hands before you put food in your mouth. Always wash your hands after you put food in your mouth. These are things that our parents and our grandparents have talked to us for years about taking care of. But within my home, unless we have visitors or somebody come by, we just do standard cleaning. Now, if we have somebody come by and visit, we do, countertops and doorknobs and stuff in bathrooms, with Clorox and stuff like that.
Kim Bateman asks, when air travel opens up again and people are opening up, what will happen in your opinion?
I think we're going to see the virus spread to areas of the country that have not been meaningfully impacted yet. The question is whether we'll see the same impact on the East Coast or not, but it's inevitable. And this, anytime you're dealing with an infectious disease that is spread mostly through respiratory secretions, it just eventually will creep everywhere. The purpose, I think the main focus is your community being able to recognize that people are, find the people who are sick, isolate them, and do testing in their immediate cluster. I don't think that we can realistically do the type of contact tracing that they do in South Korea or China, partially for partially just because of the magnitude of it, but also it becomes low yield. The people that say I was sick and had this disease, the people that I come in contact that are the absolute most likely to also got it from me are going to be my immediate family. And then any place that I spend any meaningful amount of time. So my work contacts. And I don't think that you need to contact trace to the last restaurant I went to and how many times I go to Walmart and how many other people were there. It just, the practicality of it's just not there. But, you know, as we travel through the country, and sorry, I didn't answer the question again. So the question was when we start to see domestic travel happen more, what do you think is going to happen? And I think the main thing is we will eventually see it spread in a little more density into other places that haven't seen it to this degree yet.
What do you say to the people in Southern Utah who say that this is all a hoax or that we're overreacting?
They wouldn't say that if they saw what I saw. So the question was, what do I say to people who think this is a hoax or think we're overreacting? First of all, it's definitely not a hoax. The amount of illness and death and dying that we've seen with this is unprecedented compared to anything we've seen in my lifetime. And you probably have to go back to, if you exclude war, you probably have to go back to the influenza outbreak in 1918, 1919 to see anything that was similar. As far as overreaction, you know, when you look at it retrospectively, the hard thing with preventative medicine is you don't know if you prevented anything. If I get a flu shot this fall and I don't get influenza this winter, well, was it because I got the flu shot or just I wasn't going to get it? I was as likely not to get influenza with the shot as I was with it, at least statistically. And so how do you know if you prevent anything? So, you know, when we saw the original projections of, you know, if we do nothing, we could see upwards of 1 million deaths in the United States. And then people would point back to that and say, well, we didn't see that. Well, but we did something. We, you know, shut down our schools, we shut down society, we stopped flying. And so we don't know how much we actually prevented doing that. That said, I think that if you look at most areas in the country that have had very minimal impact, you know, they look at that and say, man, maybe this was an overreaction. And they're probably right. But whenever you're dealing with something that we've never dealt with before, you don't know how it's going to respond. So we had no idea how quickly it could spread from community to community, how easy it would be to spread other ways. And so, you know, in one way, I sympathize with people that say, did we overreact? And you know, if you're sitting in Enterprise, Utah, it probably was an overreaction because you haven't had any cases come into your area. If you're in Boston, Massachusetts, they probably think we underreacted because of the severity of the outbreak in their area.
This is a two-part question, but what are your thoughts on herd immunity and people that already have comorbidities like diabetes? Are there any additional precautions that they can take?
So the question, the first part of the question was, what are my thoughts on herd immunity? And I'm going to take that first, and then we'll take the second part. Herd immunity is not something that we would gain. Herd immunity is something that will happen over several years process. People keep thinking, you know, if we can just get 80% of the people exposed, everything will be fine. But that's just not how herd immunity works. It takes several years of an infection circulating through a population to build that immunity up. And what plays into this a little bit is the things we don't know about COVID-19. We do not know if you get sick, if you will have a lasting, durable immunity. We do not know if you're going to have any immunity. Or we don't know if it'll be partial. And we'll go back to two things. One is coronaviruses in general, as a class, make up about 20% of the viruses that give people the common cold. They circulate every single year. they rarely raise to any level of concern because they hadn't made you that sick. But there's a reason why they continually recirculate through, and that's because the virus mutates enough that the immunity I gained from my cold today maybe isn't going to be effective 3 years from now. It might be effective next fall and the year after that, but my antibodies will drop over time. The virus may slightly change, and so I get this cold again. And so that's issue one with coronaviruses. The second one is that if you take an infection like influenza, and you take it across the community, there are varying degrees of immunity that people will have to that virus. Some people will have no antibodies because they've never been exposed. Other people will have some immunity that will give them partial protection because of previous vaccines, exposures to other strains of influenza. And so they develop, as a community, you have this heterogeneous host of people who are going to respond very differently to the same infection as far as their immune response and their ability to get sick. When this first came out, there was zero immunity to this virus in the communities. And so whoever got sick this time around will potentially be building to that herd immunity, but it's going to be several years before you see it build up enough to give us any meaningful improvement or a meaningful impact. And then you don't know, the people who got it this year, are their antibodies going to wane in 3 years, and now they're more susceptible again. And so I think as we get more people to have some immunity, we will at least feel, I don't know the right way to say this. I'm gonna give up. I can't get it in my head. So the second part of the question was if you have comorbidities like diabetes or vascular disease, what extra precautions should you take? And so the first one I would say is make sure that your medical conditions you have are as controlled as well as possible. When you have diabetes and you have excellent control, you're going to have fewer complications than if your diabetes is poorly controlled. If you have high blood pressure, you want it controlled as well as you can. You want to take the medications that treat those underlying conditions to optimize your health as much as you can. The second thing is, I think that you just take the same precautions we talked about as far as hand washing, good hand hygiene, mask usage. And then if you happen to be in an area where there's a major outbreak, then man, work from home if you can, take some time off and isolate yourself.
It sounds like it's not a matter of if it happens, but when the virus kind of breaks out here. What steps can we take once we have sick people in our homes and our families? And are there any other treatments that can ease the severity?
So the question was if there's an inevitability of it coming to our communities, what steps can we take to help ourselves at home, keep it from spreading in our communities as much as possible? So there's a couple of things, and these are some of the things I hope that we will change as a society as there's a couple of good things I think will come out of this. One of them is that if you're sick, don't go to work. If your child is sick, don't send them to school. And this applies to any illness. The second is that employers will be more willing to say, okay, you are sick, please stay home. Don't bring this infection to my work place of work. And so those are the first two things. If you have somebody sick, keep them in their home until they are, the CDC recommendations are right now, you have to be fever-free for 72 hours without using any medication, and you have to be at least 10 days from the onset of your illness. At that point, they feel that the odds of you being infectious to other people is extremely low. If somebody was sick in your home, you would want to try to isolate them as much as they can during that 10-day kind of quarantine period. They stay in their own room. Hopefully they can only, use just one bathroom that's not shared by anybody else. And then hand wash, clean your surfaces, especially any areas that person has went into. And then be very aggressive if somebody has symptoms, have them tested so that if there's a second member in your family, they can also go under the same kind of quarantine. And that I think applies to our cities and our populations as a whole. Is we need to be able to rapidly identify the people who have the disease, trace contact around their immediate contacts, and then keep them sequestered from other people until they meet the criteria to be able to be allowed to kind of integrate back into society.
Do you suggest getting an antibody test?
No, not from a standpoint of anything meaningful now. And so the only purpose I can see of the antibody test right now is for researchers to have a better understanding of how much this may have penetrated into the communities. The trouble with the antibody test is we can't take the results of that test and say that I am immune and that I will not get sick if I get this again. Nobody can make that guarantee. The second thing is when the FDA loosened all the regulations for standard, how do you go through the process of getting a test approved? They lifted all of that back in the beginning of March when we were struggling for this. And so there were last count, there was 113 different antibody tests available. Nobody knows really how valuable any of these tests are and whether they actually tell us what we think they tell us. And my guess is over the next 6 months, those 115 will be whittled down to about 5. And so unless you know the sensitivity of a test, which means the odds that a positive result means I actually have the disease, or the specificity of a test, which means the odds of a negative result, meaning I truly didn't have the disease, until they can actually test that out, I just don't see much value to it for an individual. Researchers will find value in it, but we shouldn't make any decisions on regulations as far as school, regulations as far as business or work based on antibody tests.
As a parent of children who you want them to return to normal life as much as possible, but still protect them, what kind of activities could you let them participate in? Can they do sports? Can they visit their friends?
So the question is, as a parent, what activities would I feel comfortable with my kids participating in as far as friends, sports, school, and things like that? And I think I think the answer to this is similar to what I've said before, is we've got as a society learn how to live with this virus. And so if I'm in an area where there's very low volume of disease, I'm okay with my kids playing at friends' houses. I'm okay with them playing sports, particularly outdoor sports. And then, just kind of the same things, wash your hands while you're at a friend's house. If you're going to eat, wash your hands. And when you come home, you're going to wash your hands. And then if we start to see more activity in the community, I would rein that back a little bit, limit the contacts. But overall, like I said, I think we have to learn as a society how we're going to integrate this into our lives. It's going to be different than what it was. Life and society are going to be different than what they were 6 months ago, particularly if this virus becomes something that we have to deal with on an annual basis.
What experience from New York will you never forget?
So the question is, what experience in New York will I never forget? I think listening to the overhead calls, I will never forget that. I wouldn't say I have PTSD from it because it doesn't bother my sleep, but those situations, whenever we hear a code call, it raises your adrenaline up and it really gets you alert to what's going on. To have it happen that many times, that'll be something I'll never forget. The second thing I don't think I'll ever forget is I am not going to forget how sick these patients were. It truly was astounding to me, the severity of illness of the people that they considered not necessary for ICU care. It was just unreal.
Any other questions from anyone? If not, Jared, we sure appreciate your service back in New York, and we appreciate you taking time out of your busy schedule to join us. And thank you to everyone who participated in this Learning Lives Forever virtual event. And we look forward to seeing you again. And please stay healthy.